I haven't been clear, or any of us haven't been clear in presenting to you, I think you should feel free to unmute your line using *6 and just say, I have a question. I want to begin by just introducing myself briefly. My name is Barbara Moore, and I have a doctorate in nutrition, but my field of specialization has been obesity, and I've been in the field of obesity for more than 30 years. And participating with me this morning is Rachel Pahut from the Marias Medical Center. And Rachel, could you just introduce yourself?
Yes. Like she said, my name is Rachel Pahut, and live here in Shelby. I work at Marias Medical Center, and here I do education, infection prevention, diabetic teaching, and employee health. So it's a small critical access hospital, and I was able to help Barbara with this project.
Thank you, Rachel. Mary, could you introduce yourself?
Hi, this is Mary McCourt, and I work at the Missoula City County Health Department in the Health Promotions Division, and I am the Active Living Coordinator with the main emphasis being on Missoula Active Kids, an obesity prevention project.
Thank you. I just wanted you to make note of the fact that my email address is on the title slide for the presentation, and if for some reason you would like to contact me directly after the webinar at any point, tomorrow, weeks from now, months from now, whatever, feel free to contact me with any questions that you may have. And Shalina, I'm having trouble advancing the slide from the keyboard. So this morning, the topics that I'm going to try to cover in differing amounts of detail are the planning of a surveillance or a screening program, safety considerations, confidentiality considerations. We're going to talk a little bit about the importance of engaging parents in the process if you're going to do a community-based either screening or surveillance program. It's important to figure out how to engage parents in the planning process as well as in the implementation. And it's very important to include any local healthcare professionals in your planning process. These are the people that perhaps parents might be referred to if problems are discovered with children in the school system or in the community surveillance or screening program. These are the people to whom you'd refer parents, and so it's important that you include healthcare professionals that are in your community in the planning process so that they are prepared should referrals take place. We're going to discuss a number of factors that you might want to consider, and we're going to discuss an approach, a way of proceeding. Of course, you may find that in your community you want to tailor that or change something that we discussed today, and basically having taken a look at what's going on around the country in order to prepare for this presentation this morning, I can tell you that there are lots of ways in which people have tinkered with the approach, and so you just have to do what works in your community or in your school system. We're going to discuss the importance of measurement protocols and the adoption of appropriate measurement protocols, and I should add that training is really a major topic, and we're not going to go into detail on training because training really needs to be done face-to-face. But I can't emphasize the importance of training and learning how to take precise measurements that are repeatable. That is of critical importance. We're going to talk about growth charts, BMI growth charts, and how to calculate body mass index or BMI and plot the age and sex-specific BMI percentile. We're actually going to discuss how to do that manually, but fact is that you don't actually have to do it manually. I want you to understand how it's done and what these growth charts are about and I want you to feel comfortable with these growth charts, but the fact is that there are programs now, there's software that will do all the calculations for you. I wanted to give you some background information about the problem of childhood obesity in order to frame this entire discussion for you. What you have on your screen is the Montana's current health ranking that was the work of Kenneth Thorpe. Kenneth Thorpe was asked by the United Health Foundation, the American Public Health Association, and Partnership for Prevention to do health rankings and to discuss health rankings in every state in the United States. So that's why on the left side of this graph it goes from 1 to 50 because there are 50 states. So Montana in 1990 had a ranking of around 13, and today it has a ranking of 26. So since 1990, our health ranking in our state has steadily declined. And one of the important factors that has contributed to our declining health ranking is the tripling in obesity prevalence in the state of Montana. And so one of the things we'd like to do is to address that, the way in which that's contributing to our declining health ranking. On this slide, you're looking at the data that were collected through the National Health and Nutrition Examination Survey, which is referred to as NHANES. So these are actual measured data. These are not self-reported data or data reported by parents about the heights and weights of their children. These are children who are actually measured. And the data are, on the left, two sets of bars are for children ages 6 to 11, and on the right, two sets of bars are children ages 12 to 19. And you can see in yellow that the prevalence of obesity in these children, was around, was under 5%, which is what you would expect for a population of normal children. But here on the right, shown in pink, is the tripling, more than tripling of obesity prevalence in this particular age group in boys. And so you're looking at a remarkable increase in the prevalence of childhood obesity over the past several decades. Anybody have any questions? Now, the consequences of...
These slides going to be available to us after the webinar?
I'm sorry?
Will these slides be available to us after the webinar?
Yes, the entire webinar will be available to you and to anybody else that has access to the web.
Thank you.
Welcome. As a consequence of this increase in childhood obesity, there's been a dramatic increase in pediatric diabetes that is now type 2. Now, remember, there are two types of diabetes, type 1 and type 2. Type 1 is the genetic type of obesity. They used to call it juvenile onset diabetes. And type 2 diabetes was called maturity onset or adult onset diabetes. And it is the type of diabetes that is related to obesity. And it used to be, when I was a graduate student in the 1970s, we were told that maturity onset diabetes didn't occur in anybody under the age of 40. It was almost unheard of to have type 2 diabetes in anybody under the age of 40. And here it is, 30 years later, and we now have 9-year-old children being diagnosed with type 2 diabetes, and these children are invariably obese. So you're looking at a dramatic increase depicted on this slide of pediatric diabetes, type 2, that used to be less than 4% of the newly diagnosed cases of diabetes in 1990. And now in some places in the United States, it's 20% or even higher of the newly diagnosed cases of diabetes. Now, this is a complicated slide, and it just was published yesterday. Actually, today, it comes out in the New England Journal of Medicine. I saw this, these data presented by Paul Franks at the obesity meeting several years ago in Boston. And basically, what he had done is he had started this study in the 1960s, and he was studying Pima Indians, and he was measuring the children in the 60s and then following them for 35 years until, regrettably, many of these children had died. Now, they were dying in their 30s and 40s, and some of them were dying in their 50s, but nobody in this study was studied beyond the age of 55. So what you're looking at is the survival curves of 4 groups of children. He broke up the children into 4 groups based on their BMI. And the children in the lowest quartile for BMI are the leanest children, and they're shown in black. And the children in the heaviest quartile are shown in green. And the green,
Barbara, is that green or gray?
It's actually green on my screen. It may be gray on your screen. So there's black is the leanest quartile, and this gray-green color is the obese children. And they are in the heaviest, the top quartile for BMI. And they're, by the time they were in there, at the end of the study, more than twice as many of the obese children had died as compared to the lean children. So, and the largest the single 2 most important predictors of early death were obesity and impaired glucose tolerance. Now, mind you, these children didn't have diabetes when they entered the study. And in fact, they had a lower glucose level than is considered to be impaired glucose tolerance today. So they appeared to be healthy, but as it turned out, they developed impaired glucose tolerance, and many of them developed diabetes. So you can see that they, a rather large percentage of these, like 27% of the heaviest children were dead within 35 years. Now, this is a slide that shows you that even if you don't die, there are other things that happen to children who are in the heaviest quartile. In this particular slide, we're looking at NHANES 3 data. And in the case of NHANES, they study the prevalence of major depression using a clinical screen that is considered to be appropriate for diagnosing major depression in teenagers. So they're studying children between the ages of 15 to 19. In NHANES, they actually study children who are younger than that, but they only do the major depression screen on children in the age group of 15 to 19. So here you're looking at on the x-axis, you're looking at BMI percentile groups with the lean children on the left. Boys are shown in red and girls in green. And then on the extreme right, you're looking at the heaviest children who are at the 95th percentile or above. So these are the obese children. And about 1 out of 3 girls and 1 out of 5 boys is diagnosed with major depression in this NHANES data set, which is a really strikingly high prevalence of major depression in these children.
Barbara, this is Mary. On the NHANES way of gathering data, how do they actually do the screening? How do they get the referrals? How do they pick their population?
In NHANES, the NHANES study is, by law, it is designed to be nationally representative. In other words, the NHANES group is at the National Center for Health Statistics, has a mandate to get nationally representative data on the American people. And as part of that, they study children. And so these children are selected at random throughout the United States. And NHANES owns these gigantic trucks that literally drive around the United States, and they measure people, including children. So these are children who have been brought into the mobile laboratory that NHANES runs, and they are measured, they're weighed, they're put through a whole battery, bloods are drawn, they're put through a whole battery of tests, including these tests, these questionnaires that the children are put through for a variety of topics, health outcomes, one of which is major depression. And there are, I forget how many studies are involved in this diagnosis, but I mean how many questions are involved in the diagnosis, but I think it's like 4 or 5, what do you call them, validated questions for the diagnosis of major depression.
Thanks.
Barbara, this is Minky Medora in Missoula. I don't want to get ahead here, but do you know if you'll have information further down on the relationship between income, poverty levels, and obesity, as well as depression-related obesity?
No, I don't have that on this presentation.
Thanks.
You're welcome. I wanted to just take a moment to discuss how obesity is defined in adults, because we're going to be talking about how obesity is defined in children, and it's in marked contrast to the simplicity that is it's sort of straightforward to evaluate it in adults. Children are much more complex, but usually, not always, but usually adult obesity is defined by the body mass index, which is the weight expressed in kilograms divided by the height expressed in meters and then squared. So, and I've included the equation for weight and height if you're using pounds and inches, just for your information. So in adults, overweight is defined as a BMI of 25.0 to 29.9, and obesity is defined as a BMI of 30.0 or higher. Now, in the case of children, it's a much more complex process by which children are evaluated. So the body mass index is defined exactly the same way. It's weight divided by the square of height. But in the case of children who are constantly growing, it requires that you measure carefully the height and weight. You know, so often studies of adults involve self-reported heights and weights where the researcher simply asks the adult, how tall are you and how much do you weigh? Children, that's really not an appropriate way to study children. You need to carefully measure their height and weight, and you need to know their exact age on the date of measure, because you need to calculate their age in months in order to use the growth charts for determining their BMI percentile. So what you do is you use a CDC growth chart, and they're easily obtained by downloading them from the CDC website. These growth charts were published by the CDC in the year 2000, and there's one for boys and one for girls, and I'll show those charts to you in a minute. And then you use these growth charts to plot the age of the child against the BMI of the child, and then you go on to figure out the percentile, and I'll explain that to you in a minute. But the children who fall between the 85th and the 95th percentile are categorized as overweight, and children who fall at the 95th percentile or higher are now categorized as obese. Now, when you read the literature, you're going to find that people don't always use this categorization. They don't always use these terms, and that's because up until recently, children who were in the 85th to 95th percentile were referred to as at risk for overweight, and children in the 95th percentile or higher were considered overweight. So the term obese was not used until fairly recently, within the past 5 years. what that means is that the literature can be confusing because you're not sure what's what. When they say overweight, you're not sure whether they mean 95th percentile or 85th percentile. So what you need to do is not focus so closely on the terms and instead concentrate on the percentiles that are reported, because that's what tells the story. What you're looking at in this slide is a hypothetical group of children of a single age, whether it's 5 years old or 9 years old or whatever. We're talking about a group of children all the same age who are normally distributed. And so what we're focusing on is children who are out here to the right tail of the distribution curve, who are at the 95th percentile or above. Those are the children who are categorized as obese. And children who fall between the 85th and the 95th percentile are considered to be overweight. I'm showing you the 50th percentile, of course, is the mean of this distribution, which is normal. And we're also going to just talk a little teeny bit about children who fall below the 5th percentile, who are categorized as underweight. And I think that if you're going to go to the trouble of measuring children, you should be sensitive to the fact that there might be some children who are underweight. Although in America today, the percentage of children who fall below the 5th percentile is vanishingly small. In fact, Rachel, I'm trying to remember, up in Shelby, I think it was less than 1% of the children were underweight. Isn't that right?
Yeah, that sounds correct. Mm-hmm.
And Mary, in Missoula, what was your finding?
It was barely 1% underweight.
So you would expect that approximately 5% of children actually fall below the 5th percentile. But in point of fact now, in America, this entire curve is shifted to the right, and we now have very, very few children who fall below the 5th percentile. Now, on this slide, you're looking at the CDC growth charts that, as I said, were published in the year 2000. And notice that girls are in red or pink, and the boys' growth chart is shown in blue. And one of the things I've noticed about these growth charts is that the numbers on them are tiny, tiny, tiny. So what I've done is I've typed 5th on the line that represents the 5th percentile. So remember that we're looking at age on the x-axis. We're looking at BMI on the right axis. And so you'd start out by entering this chart. You enter this chart by calculating the age of the child, and you plot the age of the child against the BMI of that child. And then you figure out where those two lines intersect, and then you find the percentile curved line that falls closest to the point of intersection. And I'll illustrate that more clearly in a subsequent slide, but I wanted you to just look at the shape of these two curves. Look at the shape of the curve for the girls. You see how far apart they spread by the time they're in their late teenage years, how far apart the 5th and the 95th percentile lines are. Notice that for boys, that they're much closer together. So essentially what you're looking at is the distribution of BMIs that you would expect for children at each age that's shown on the x-axis. I know this is complicated, but does anybody have any questions about this? I'm going to show you more detailed examples using an actual hypothetical child in a minute.
Barbara, this is Mary. So in looking at the girls' chart especially, basically what you're saying then is that as girls grow, there's a very wide variance of what is normal, healthy weight.
Right. That's right.
And so then that, of course, collides with the culture that produces only one way to look, which is skinny.
That's right. That's a takeaway from this slide. That's right. Any other questions? Okay. So again, what you're looking at on these growth charts is you should be thinking about this distribution, but you're looking at it at various ages. So the age, of course, is shown on the x-axis. And so essentially, it's like you could slice through this slide at each age, and you would get a distribution like this. So this is just a picture of the distributions. Now here's a growth chart for boys, which shows you an interesting thing, which is that BMI declines until approximately ages 3 to 5, and it'll differ from child to child, but BMI at birth is higher than the BMI of a child between the ages of 3 and 5. And then at that point, the child's BMI starts to increase, and it increases throughout childhood, which is why, of course, the BMI curves go up as the child gets older. So here you've got a boy who had a BMI of 19.3 when he was 2, and his BMI dropped to 17.8 when he was 4, and then it increased to 21.0 by the time he was 9, and 25.1 by the time he was 13. So what I want you to appreciate is that if you take measurements of height and weight for a child and you plot it on the growth chart, it could appear anywhere. It may even appear at the 95th percentile. But what's important to know is that the entire history of that child is important for understanding their actual weight status. And I'll explain that better in subsequent slides. Here's an actual child, hypothetical child, who's 10 years of age, and she has a BMI of 19.3. And her BMI percentile I've plotted for you. So here's the age, 10. Here's the BMI, 19.3. The point of intersection, right here, falls between the 75th percentile and the 85th percentile. So she's defined as normal weight by this single measurement. Now, 2.5 years later, she's measured again, and she's 12.5 years old, and her BMI is just below 24, and now her BMI is just above the 90th percentile. So she would be categorized as overweight, and the interesting thing to note is that she used to be between the 75th and 85th. And so her BMI trajectory is starting to take off. And you can, even though she's categorized as overweight, she's not yet obese. Remember, 95th percentile is the cut point for obesity. But her growth trajectory suggests that she's at risk for becoming obese. And it's this slide that I hope will help you appreciate that if you have a history on that child, and if you have repeated measures of her BMI percentile in her youth, it helps you to better understand whether a single measurement taken at any point in time is indicative of her future risk. I mean, what you would like to see is you'd like to see a child that consistently tracks along a percentile, or at least within a range of 75th to 85th. You would have liked to see this child continue roughly within that range. Instead, she has jumped up quite a bit to be above the 90th percentile. Now here's a boy who I showed you actually this slide earlier. He's tracking rather steadily throughout his life at the 95th percentile. You see how these various measures are placing him at the 95th percentile. I want to ask you, is this boy obese? Anybody want to hazard a guess?
This is Mary. I'm going to hazard a guess that he's not obese.
Yeah, Mary, I would agree. Now, for a child like this who is so consistently tracking at the 95th percentile, technically he's categorized as obese because obese is defined as 95th percentile or above. But the truth is he may be what we call a large child, and he may not be overly fat. And really what should happen is that a child like this could be evaluated by a healthcare professional. They have ways of evaluating children. They can take skin folds. They can do bioimpedance assessments to determine whether his fat content is overly high. But I would actually be reasonably confident that a child like this is not necessarily obese. He's probably just a large child. I found an article last fall in which it was a survey had been done of parents, and the article said that children's growth charts don't measure up with parents. And this survey revealed that many parents don't understand how to read or interpret growth charts. And you can see why. I mean, we've spent the past 15 or 20 minutes talking about growth charts. They are complicated, but they are really very, very useful and very helpful. And so I'm encouraged that a lot of people are on this call who I hope will come out of this webinar with a better understanding of what growth charts are about and how to explain them to parents. So I'm hoping that you'll be part of the solution of this problem. Now I want to ask you a question. In a normal population of 300 children, how many would you expect to meet the definition of obese?
It should not be any more than 5%.
Say 5 to 10.
That's right. You would not expect it to be any more than 5%. So that would be 15 children in a normal population of 300 children. You would expect 15 children to meet the criteria for obesity, since the definition of obesity is the 95th percentile. So only 5% would be expected to be obese. And here's what you find, however, in America today. This is a study by Bob Whitaker and his colleague, and they were looking at national data on preschoolers, and they organized the data by ethnicity. And what they found is that instead of the expected 5%, which would be here, they have, even Asian preschoolers now have a prevalence of obesity that's double that. White children are nearly triple that. Black children are nearly 4 times that, and same thing for Hispanic children. And American Indian children have 6 times the expected prevalence of obesity. And these are just preschoolers, mind you.
I have a quick question that reverts back to something you had talked about with the growth chart. With the male that you said you wouldn't expect to be obese, is it just because he was following that pattern? And if he would have been, like if he would have jumped up higher off that pattern,
if he had started out at the 50th percentile, for example, let's say he was at the 50th percentile earlier in his life, and now he was up at the 95th. That would cause much more of a suspicion that he was overly fat. But the fact that he's steadily tracking at the 95th would suggest to me that he's simply a large child and not necessarily an overly fat child.
But if he would have stayed on this path, the 95th, and then but jumped up higher, then just because he's following this pattern.
That's right. If we measured, okay, here he is at age 13, But if at age 17 he was up at the 99th percentile,
Okay.
then you would say, oh, well, maybe this is this is different. So again, knowing the history of the child and knowing how the child is tracking is what sort of tells the tale here. But remember, it's not that you can definitively figure that out on a growth chart. You really do have to refer this child to a healthcare professional who has the tools needed to do further assessments of the child. And it's really true that, I mean, there was one study I saw recently which showed that only 25% of the nation's pediatricians are using growth charts, much less have additional tools required to evaluate whether a child is obese.
Okay. All right, thanks for going back. But with that, I mean, can we say that maybe they just don't, then can we not trust the statistics as far as saying, man, they're really not being measured correctly? And
well, the statistics that I rely on are the statistics gathered through NHANES. And NHANES has the tools necessary not only to measure heights and weights accurately, but they also have tools for assessing body fat content.
all right,
They even have DEXA on the NHANES mobile laboratories.
Okay.
And
Great.
DEXA is now considered the gold standard. You know, it used to be that underwater weighing was the gold standard for assessing obesity, and now DEXA is considered the gold standard. And NHANES has DEXA.
Very good. Thank you.
You're welcome. All right, on this slide, I'm just looking at the economic factors involved in childhood obesity. This was a study that assessed the cost of childhood obesity at $15 billion, and one of the quotes from that study was that children treated for obesity are roughly 3 times more expensive for the health system than the average insured child. And they have much higher rates of comorbidities such as diabetes, hypertension, high cholesterol. They have triple the rates of hospitalization, and they have at least doubling of physician visit rates. Now, again, this is a Whitaker study that showed that if a child was obese, the child faced a much higher risk of becoming obese himself or herself. And if the father was obese, the risk was almost doubled. If the mother was obese, it was 3.5 times higher. But if both parents were obese, they had a more than 10 times increased risk of that child becoming obese. And so we now are presented with a vicious cycle where we have more and more obese children are growing up to be obese adults, and they're becoming obese parents. So, of course, their children are more likely to be obese. So, you know, what can be done to break the cycle? And this is a report that was published by the Institute of Medicine in 2005, in which, and this was a report that was mandated by Congress. Essentially, they turned to the CDC and the USDA and even the Department of Defense, and they said, you will fund the Institute of Medicine study that will look into this issue of how to prevent childhood obesity, and you'll put together an action plan for America to help us figure out how we're going to address this growing problem. And in this report, and I actually have a couple of extra copies, and people can contact me if they're interested in obtaining a copy of this report. In this report, for the first time, school-based screening programs were recommended to measure children and identify those who are at risk. And basically, a screening program is one in which you not only measure the child, but you send confidential letters home to parents on the BMI status of that child. And for children for whom it's appropriate, you encourage referral to a local health professional for more thorough evaluation. And so a screening program is an expensive program, but it was identified as a good strategy for childhood obesity prevention. Now, what's interesting is that the so-called, one of the most authoritative bodies for making health recommendations to our nation is the U.S. Preventive Services Task Force. And in just a couple weeks ago, in pediatrics, they finally made an authoritative recommendation on screening for obesity in children and adolescents. So this task force now recommends that clinicians screen children, and by the way, clinicians include school nurses or nurse practitioners, and they recommend that clinicians screen children, school-age children aged 6 years and older for obesity and offer them or refer them to comprehensive intensive behavioral interventions to promote improvement in weight status. And the evidence in support of this recommendation is given a grade B, which is a pretty solid grade. You'd like to see grade A, but grade B was strong enough. The evidence is now considered strong enough to go with this particular recommendation, which was published in Pediatrics in January. So this is sort of, now there's, what that means is that the Institute of Medicine as well as U.S. Preventive Services Task Force are in agreement that screening of children is recommended. Now, a lot of schools are doing that, but on the other hand, there are schools that can't afford a screening program, and surveillance programs are an option as well. Surveillance programs measure children, heights and weights, and then they calculate percentages of overweight and obesity at each grade level that they study, breaking out the data usually by sex. And they use this as a way of doing a health snapshot of their school children or their community, and they use this information to inform policy and to track progress in their community. So you can do a surveillance program of multiple grade levels, measure the children every year. You could measure the children every other year. And so basically, if your budget is limited, you can do a surveillance program and you can get a snapshot of the health status. Now, the disadvantage of a surveillance program, of course, is that you can't send the information home to the parent, and you can't encourage the parent to refer their child for further evaluation by a health professional. So that's the weakness of a surveillance program. But sometimes a surveillance program can be used to collect data that can help influence the administration or political leaders in the community that a screening program is needed. So there's really a surveillance program is a very important step towards prevention in that respect. So Mary, since Mary has just completed a surveillance program in Missoula, and Rachel has completed a screening program in Shelby, I'm delighted that they're on this call so that you can ask them questions about the practicalities of conducting such a program. And so what I'd like to do is plow through the rest of my presentation. Take any questions that you have for clarification right now, but I just want you to know I'm planning to save a lot of time at the end of this presentation for you to ask questions, and you can ask these questions of both Rachel and Mary about some of the practical and logistical problems encountered conducting these programs. So if there are any questions that you need right now for clarification before I move on, go ahead and ask them now. If you want more detailed information on logistics, save them till the end of the presentation. All right, so when you're trying to plan either a screening program or a surveillance program, one of the things you have to think about is the equipment that's necessary for conducting such a program. You need to be able to accurately measure heights and weights of children. You have to have the staff needed to do that, especially if you have a large school system. I think Mary measured almost 900 kids. Rachel measured almost 300 kids. So, I mean, this is a lot of work. So you've got to figure out who's going to do it, how you're going to organize your staff, and how you're going to enter into the school system and actually take these measures. I mean, historically, school nurses have done this sort of thing. When I was a kid growing up in New York State, we were measured every year by the school nurse. We would line up outside the school nurse's office, and she would, check our hearing and our vision at certain grade levels, but we were measured heights and weights every year. So this used to be routine in school systems throughout the United States, but it no longer is. You have to get your hands on good protocols for measurement of height. You've got to have clinical quality professional equipment, and you've got to train staff so that they are capable of taking precise measures of these children. Now, I've got on this slide wellness committee. I mean, by law, any school system that receives school lunch or from the USDA is required by law to have a wellness policy, and it's recommended that a wellness committee be appointed to develop this policy and post it in the school. The interesting thing is that a wellness committee be very helpful in guiding a screening program or a surveillance program for childhood obesity, because these are the people that you can sit down with, and you could include the school principal or maybe the PE teacher and maybe some parents and maybe even some children from the school system and local health care professionals, and you can sort of map out a strategy for assessing wellness in that school. And they may say, we think we should conduct a screening program or a surveillance program. And so then you have sort of support within the school that will encourage you to move forward on such a program. Be sure to include parents in the wellness committee, consult with the PTA. That will help a lot for garnering acceptance of this community. And by all means, include local healthcare professionals because they're the ones to which parents will be referred. So they need to be, and there's a lot of evidence that if you don't include them, they're completely taken by surprise, and they don't like that. And so they can actually throw a monkey wrench into a program of screening, which has been documented in other school systems throughout the United States. So by all means, include them in your planning process. The other thing you need to think about is that you're going to generate a lot of data, and the data are highly confidential. So you need to be careful about how you handle your data, where you store it, how you keep it safe, and remember that if you're doing screening and you intend to measure that same child a year or 2 or 3 years later, you have to be able to match up that child, Mary Smith, with the same Mary Smith. And remember, there are lots of Smiths in town, probably. So you have to figure out a system for storing the data and keeping track of who's who, so that as you build the history of a child, such as that little boy who was measured at age 2 and again, at age 13, how are you going to do that? How are you going to keep the data straight? So that's an important challenge that screening programs face. Now, the U.S. Preventive Services Task Force recommendation for screening is in your handout. It is Appendix E in your handout. And there is a section in that handout that relates to safety. And they had considered that the risk, the safety risk associated with screening is, I think they said, not greater than small. And an important way to minimize risk and keep children safe is to measure them with respect, to treat them with respect and measure them in a private place where other students are not around, and their data is not discussed with anyone but them. And usually for young children, you don't even discuss the data with them. You simply take the measurements in a very neutral way, and you don't even assess the student. I mean, basically, and I think Mary will speak to this, and maybe Rachel too, during the question and answer session. But basically, some students are very anxious about being measured. Anxiety in the heaviest girls and in small boys who are small for their age can be, you can expect to see that. But the idea is to conduct this, this process of measuring kids in a neutral and matter-of-fact way that's respectful and private. And you should be able to minimize that trauma. During the question and answer section, you can discuss this issue of opting out. Many school systems that have implemented screening programs give parents the right to opt out, to opt not to have their child participate. So that's parental opting out is one thing for you to think about. And I think in the case of Missoula, the student was given an option of opting out on the day of measurement. And so there are pros and cons of that, and you can discuss that with Mary and Rachel during the question and answer session. The issue of confidentiality, you have to remember that these data are as sensitive as data on IQ or data on hearing or speech or vision problems. So you've, as I said before, you have to think about how you're going to use the data, how you're going to analyze it, how you're going to store it and maintain it in a safe place. And especially if you have to store it for years, if you're doing a screening program, and how to match up data for a given child over a long period of time. Ordinarily, you would disclose the data only to the parents or legal guardians of the child. There are instances where nurses have chosen to discuss the data, but usually it's not with young children, it's with teenage children who they felt it was appropriate to do that. So, I mean, you have to decide whether you're going to conduct a screening program or whether you're going to conduct a surveillance program. Again, what's going to help you make that decision is deciding how you're going to use the data. What are you going to use the data for? If you're aware of severe budget constraints, it may be that only a surveillance program is an option for you. Again, I can't emphasize enough how important it is to alert parents that you're going to conduct a program, whichever it is, and to invite them to opt out if they wish to do so. In the case of Pennsylvania, Emmaus, Pennsylvania started doing a program in 1998, and they found that there was tremendous pushback on the part of parents that first year that they conducted their program. And then they initiated the opt-out. And over time, very, very few, and finally no parents opted out. So we've drawn upon, in putting this presentation together for you, we've drawn upon the experience that they started to collect in 1998. They're one of the very first communities in the United States to do screening in their school system, their entire school system of 7,000 children. And they found that the opting out option was very actively used in the first year or two or three, but by year 4 they had almost no parents opting out. Again, they're the ones who alerted us to the problem of engaging local health care providers and sort of engaging them and helping them prepare for referrals from parents as parents made those, sought help for their overweight and obese children. I already talked to you about the School Wellness Committee. I just wanted to give you a list of the types of members of a School Wellness Committee that can be very useful. The school nurse, food service personnel. This is a real opportunity to include food service personnel in the Wellness Committee. School administrators, teachers, especially maybe a PE teacher, who could, by the way, maybe conduct fitness assessments of children on the day that they're measured for height and weight. Parents, students, and local healthcare professionals. So when it gets right down to how to proceed, you have to focus on training of staff, and I've given you quite a bit of information in your handout about protocols, and but there's not a very detailed description of how to train. There are resources in a minute I'm sorry, I have a lot of static on the line. Are you all there?
Yes, I'm here.
Okay. Choosing, purchasing, and calibrating equipment, and how to keep your equipment calibrated over time. You need to choose the protocols that you're going to use for heights and weight measures, including these test and retest protocols. You have to figure out what dates, places, and times you're going to do the measurements. You have to establish your staff and your processes for data collection, analysis, and storage. And then you have to figure out what reports you're going to prepare and how you're going to communicate the results of your program. So here are some stadiometers that are illustrated, which show you kind of what it's about when you're trying to measure height accurately, height of a child. I just wanted to remind you that when you calculate BMI, you have the weight on the top of the ratio, and height is on the bottom, and height is squared. So any errors in the measurement of height are squared. And that's why it's important that you measure height accurately. There's a lot of excellent information on the CDC website, and there are training resources. I've given you quite a few in this presentation, which you'll be able to consult, and in your handout. And the stadiometers really vary quite a bit. So you'd like to find stadiometers that will be the best you can possibly afford with your budget. And if you have a large student body, you're going to just, knock yourself out, and you should, by all means, have a high-quality stadiometer that's going to make your job easier. I've given you a website that Mary used to purchase her stadiometer. That's just one example of, and I think, Mary, you said you were very happy with your stadiometer. Rachel, are you happy with yours?
No, I mean, it did the duty, but I think a more professional quality or a new one this year is on the record here. I was talking to Barbara about what the best type was, and
okay.
Good.
Really one of the things in looking at stadiometers, what I would suggest is you look at the size of the headpiece that comes down onto the top of the head, because last year we used a plastic stadiometer with a very small surface for the head. This year ours is a wood, and the headpiece is very large, and so it really cuts down on error.
That's a good idea. Ours was metal, but it wasn't very large.
I'm not sure what happened here. This illustration shows you how it can be backbreaking if you're measuring hundreds of students over a period of time. I mean, if you have to bend down to line up the stadiometer and get an accurate reading, it can be really tedious. There are some stadiometers that can be read from above. So, again, you should carefully research and before you make your choice and put out your money. And Mary, I think you said you spent almost $450 on your stadiometer. So this is a fairly sizable investment.
Mm-hmm.
Weight is considerably easier to measure, but weight is such a sensitive measurement from the perspective of the child. So one of the things I wanted to show you is the scale where the readout is separate and it's connected by a wire to the base. So the beauty of a system like this is that you can have the readout face you, and the child can't see the numbers, and you don't have to call the numbers out. And this is available from Tanita, but there are other companies. Tanita happens to be a company that's been around for about 20 years, and they are, it's a company I've worked with over the years. They did a lot of validation of some of their equipment at Columbia University when I was a student there. So I just happen to be quite familiar with them. And in your handout, there's a way of contacting Tanita, as well as I think one of the places that Mary went to purchase her equipment. So anyway, if you can get a scale that is of clinical quality, heavy-duty, professional quality with a separate readout that's connected to the base, like this one, then that should help aid the confidentiality of taking these measurements. The recording of data is really very tricky. You may actually need a separate staff person to do the recording of the data. One of the tricky things is the date of birth of the child. Remember that you can't use the CDC charts without knowing the date of birth of the child, because you have to figure out the age of the child on the date of measure. So what we found, Rachel, in working with data that came out of Shelby, is that the birth dates for the children were on a different list from the height and weight data. So we had to match up the date of birth for that child with their measurements, and it produces a lot of anxiety. So you have to think about, if you had a spreadsheet with the date of birth already entered for the child, and then you added the height and weight to the spreadsheet, that's kind of ideal for matching up the measurements with the right child. And I'm sorry,
Barbara, can I just tell you, we have done it 2 different ways last year and now this year, and I'm happy with this year. I wanted to share how we do it. We ask the school secretary to send the name of the child, the date of birth, the gender, and on the day of the measurements, each of the student nurses has a copy of that sheet, and we then have them hand put the measurement on that sheet, and we do not enter that into the computer, into our Excel spreadsheet, until we're back at the office. And that way, it really cuts down on, I believe, error, because when you have, last year we had a recorder, we had a 3rd person out recording those numbers when the measurements were happening on just a white, we had a white board that would wipe clean, and so once that board is wiped clean, that data was no longer available to us. And so it works so easily this way. And then you can have the school secretary either send you an Excel sheet with the birth dates that you can copy and match up with the name, or you can scan the piece of paper they give you the day of the measurement.
Right.
With the birth date. And believe me, think this through carefully, because it's vital that those measurements match up with that birth date and that gender.
That's right. I mean, you talk about doing no harm. That's critical for doing no harm.
Mm-hmm. That's so, this is Rachel. That's what we did as well, is we came with a list of all the students and their grade, and recorded on a clipboard their height and weight, and then the secretary of the school sent us their birthdays, age, and sex, and then we had to input all those into the Excel spreadsheet.
That's very helpful information. Thank you, both of you. The voice of experience. Some systems have set up, Arkansas, for example, has designed their own system for handling the data. Remember, in Arkansas, they have a state mandate to measure all the children. Initially, that state mandate meant measuring every child every year. And what a huge, massive undertaking with so many, it was very, very complicated. And they actually designed their own system because the CDC has now made a system available, but it wasn't available when that state law was passed, and so they were forced to figure it out for themselves. Now the CDC has this Excel spreadsheet, which works very, very nicely, and so I highly recommend that you look into that if you're going to move forward with either a screening or a surveillance program. The CDC spreadsheet will do all of the calculations for you. It'll figure out the BMI percentile. No need for you to do any manual plotting. It will check for error messages. It'll flag if a birth date is missing or if the gender of the child is missing. It's really terrific in that way. And it also summarizes your data for you. And it can graph your data by grade level if you use a separate spreadsheet for each grade. So here's the link to the CDC spreadsheet. Remember that there are two different spreadsheets. One is for English. What I mean by that is pounds and inches. And then there's a separate spreadsheet for metric. And metric is highly recommended. It was Mary who pointed out that so many children are not comfortable or familiar with the metric system. So the numbers in the metric system are kind of mysterious to them, and that increases the confidentiality of the data. So that's something for you to think about. And the other thing I want you to think about is shown on this slide. Here is the CDC spreadsheet in the metric system on top and the English system on the bottom. Now look at the height and weight columns for the two spreadsheets. Notice how height in centimeters is entered as 148, which is really 148.0, and 140.7. It's measured to the closest tenth of a centimeter. And the kilograms are shown in this column. And so it's 38.0, 57.7, so it's the closest tenth of a kilogram. Now look at, in the English system, height is 4 feet, 10¼ inches, which is entered as 10.25. Look at 4 feet, 7¾ or whatever the heck, 3.37. I mean, it's like a nightmare to enter the inches in the English system. Pounds are not so difficult, but the height is really difficult to enter in the English system. So for that reason, again, I encourage you to enter your data in the metric system. It facilitates data entry, and it doesn't really matter in terms of the way the spreadsheet functions. You can do either one, but in my opinion, it's much harder to enter feet and inches than it is to enter centimeters of height. Mm-hmm. Any comments, questions about this?
It's interesting to note the different BMI percentiles with the different types of measurements.
That's right.
Since the third down, you have 40.8 versus 39.9.
That's right. That's right.
Interesting.
Yeah. Now here is just an illustration of what the CDC web Excel spreadsheet looks like. I mentioned to you that it flags errors in height. Here's what happened here is that the weight was entered as 596 instead of 59.6. So it flagged that there was an error. And here, a child's gender was left out, so it flagged the fact that there was a sex error. And here, a birth date was left out, so it flagged the fact that there was an age error. So this is a pretty cool spreadsheet, which is going to make your lives easier if you decide to move forward with the program. This slide illustrates how the Excel spreadsheet summarizes your data for you. So it will tell you how many children, how many boys, how many girls were assessed, the prevalence of underweight, the prevalence of normal weight. It combines overweight and obesity together and gives you those percentages, and then it shows the prevalence of obesity alone and gives you those percentages. It doesn't give you overweight, but you can change this spreadsheet if you know what you're doing. You can change it, and you can get it to print out percentages for overweight alone if you wish.
How do you do that, Barbara?
The way I do it is I contact my programming maestro, Alex, and he does it for me. I don't do it myself because I don't trust myself to do it exactly right. But you just have to change the macros, and it's really not that hard to do. But okay. Alex is a pro, so I get him to do it. And also, he's got a lot of experience with Excel. This shows you how the CDC website will graph your data for you. It's going to give you the overall percentages of overweight combined with obesity, and then obesity all by itself. It can break it out by gender. So here you've got the boys shown here. Oops. You've got the boys and then the girls. So it really does all of that automatically, and these are the Excel tabs. So I've got the group summary tab activated to show you the summary, but here's the measurements tab and here's the instructions tab.
This is a great tool, believe me.
Yeah, you're going to love it if you actually do one of these programs. In honor of Mary McCourt, who's with us today, I started off in the research, and by the way, I'm almost done with my presentation, but I wanted to give you the website URLs for states and other localities that have done this type of work. And here I've got the report that Mary put together on Missoula BMIs in third graders, and Mary has a protocol that she'd like to share with you. And if you contact her at this email address, you can get Mary's protocol for, remember, she did a surveillance program. So you can get that from her. This is the state of Massachusetts has done a screening program. They're going to revise their guidelines in 2010. But what I like so much about this program or this resource is that they have guidelines for measuring non-ambulatory students, and it's a pretty extensive section on how to do that. So if you have non-ambulatory students that you would like to include in your screening or surveillance program, I'd say this is the best place to go for that kind of information. Arkansas has been doing these measures for years, I think since 2003. Pennsylvania's, that Emmaus school system has been doing it since 1998, so they really have a lot of great, I mean, my presentation to you was based heavily on their work. Arkansas has a website that I've given you here. They now are measuring children in alternate grades. They have very well established procedures, and you can get a lot of information. And here's Arkansas's contact information, because you might want to get in touch with them if you're going to move forward with a screening program or a surveillance program. Here's a website for Ohio. Here's Wisconsin. And here's some background reading. This is interesting reading. It's MMWR. It came out in May of 2009, and here's the URL. This is a sort of a story of statewide screening of elementary school children, and basically they looked at how well they were measuring kids. Like they had a bunch of criteria that they used to evaluate how well children were being screened. They used criteria like how well were the staff trained, and how private was the setting in which the children were measured, and it shows you that in the state of Florida they were doing a pretty bad job of screening. And so what they're trying to do now is they're trying to institute quality measures so that the children will be measured properly and in a confidential setting and a private setting. And so I give you this reference as background reading because I think if you're going to undertake either screening or surveillance, you can learn from other people's mistakes, and it's all written up for you in this MMWR. This is an article that the CDC is pushing, but it was published in 2007, and in some ways it's already dated. But still, I recommend it to you because I think it's good to kind of inform yourself about what the CDC is recommending. And I guess that's it. I'm now done, and all three of us, Mary, Rachel, and I, are prepared to take any questions you may have. So be sure to unmute your phone to ask your questions. And to unmute, it's just a *6.
Mary, this is Dorothy.
Hi, Dorothy.
Hi. Hey, and I guess this is for Barbara too, because there's recently been stuff released saying that the obesity rates are plateauing. And I'm wondering if in terms of, I think, Mary, you've done it for 2 years?
This is our second year, Dorothy.
Second year, and Rachel, I don't know how far you are in Shelby, but what, I mean, are you seeing that replicated in local data? And 2 years really isn't enough to tell, but, and also what are we, you know, Barbara, how do you respond to that, the sense that this is plateauing? And does the NHANES data show that?
Well, I think the issue is to look at where it has plateaued, because if you look at Arkansas did see a plateau, but that was after they did a huge amount of legislation and changes in school wellness, their screening tool, their BMI screening tool. They legislated daily PE. So I think you have to be careful of comparing apples to oranges in terms of that plateau issue. I think that for us, the issue is what do we say to the public, to our public, and to our decision makers. And we're not talking plateauing. We're talking, let's look at the increases since 1970, because even if it were to plateau, would we accept the current rate as acceptable? And the answer to that, of course, is no. So I don't think we're yet in the plateau. We could use the P word, so to speak. One of the things that we're seeing that's different this year is we are seeing, and we've done a total of, I think, 500 kids so far. We are seeing a much higher rate now with the girls, overweight and obesity. So now it was almost comparable last year, but we're seeing the same overall rate of overweight, a little higher rate obesity, but the breakout of the girls and boys, we're seeing a statistical difference. So,
I'm sorry?
Go ahead.
To that, I would only add the following, and that is that the rates of morbid obesity, which is defined as BMI of 40 or above, have not plateaued. They are rapidly increasing. So you have children that are, let's say, in the overweight category, and they are shifting to the right. So they are becoming increasingly obese, and some of them are entering the category of morbid obesity, and that is not plateauing. But in other words, the prevalence of morbid obesity is not plateauing.
Okay.
Any other questions?
Here in Montana, are we making an effort for daily physical activity for elementary students?
Currently, there isn't any legislative push in that direction, and I was visiting with a past legislator who has an interest in this and introduced a couple bills last session, and he doesn't feel, and this is just his opinion, that anyone is ready to take that on because the biggest issues are always the lack of funds, and so to push something that might look like it'll cost more money, and I really don't think in the school. I think we'd have a lot of pushback from the schools on this because of No Child Left Behind. They are looking at ways to carve out more time for math and reading, and so how we're approaching it at Missoula is to look at how can we get those playgrounds more active before school, at recess, at lunch, and after school, to try to carve out, what we know about the physical activity dose is that if it's done in 10-minute increments, it can, if it's in the moderate to vigorous zone, in at least 10-minute increments, it can go towards a child's 60 minutes. So how do we get those playgrounds so that kids are actually getting into the moderate and vigorous zone when they're out there? That's just one small way we're looking at it.
Does anybody want me to go through the table of contents of your handout?
Before you do that, Barbara, it's Dorothy again. I have one other question for
Sure.
these guys, if that's okay. And
Sure.
that's, we have, and I think other people on the call are probably aware, I mean, we've had some pushback from school nurses, specifically on taking measurements because of the impact on kids, and they say it increases body dysmorphism.
Mm-hmm.
Did you, either you, Mary or Rachel, experience that kind of pushback from the school nursing staff, and or did you finally obviously overcame that, but it sounds like you guys are doing the measurements.
Correct.
Have you had any of the school nurses become advocates for this?
Well, this is Rachel. We're actually such a small rural area that we don't have a school nurse. Our county health nurse does all of the nursing responsibilities with the vision and scoliosis testing and all of that. So, and she was on board. We have it's called a Toll County Healthy Coalition, which reminds me a little bit of the school wellness group. And we meet, and this project was discussed there. And the principal of the school is there, the county health. And we, so personally here in Shelby, we didn't have a lot of resistance from the school, but we did have parents who opted out with those same reasons, that I know my son is overweight, you don't need to measure him and tell me again, kind of response. So,
what grades did you do there in Shelby?
We did kindergarten through 8th grade. Mostly kindergarten through 6th. Had a harder time reaching the middle school kids, 7th and 8th graders, or lower numbers in those areas.
Dorothy, one of the reasons we picked 3rd grade is that there many, well, Ohio does 3rd grade across the state, and Idaho does 3rd grade. And some of the reading suggests that 3rd grade is a good grade where kids aren't as concerned about body image. We did have opt-out. We didn't, our biggest sell was to the principals, and that was a hard sell, and it took a while. So we have 13 school districts, and we did it in 11 in one private school. So there was some negotiating on how the data would be used, and since ours was surveillance and not screening, there was, I think, a little less concern because they weren't worried that angry parents would call them back. Okay. But we certainly have the student opt-out opportunity for that, and how we handle that is if a student, as a student is approaching the measuring site, if they, and I greet the students, if they appear anxious, I inform them that they have the right if they don't want to participate. And so we're trying to cover that. We've had some interesting experiences on this issue, though. We definitely have. Go ahead.
Could I refer you to your screens? What I've done is I've taken the handout and put it on the screen, and I've taken Appendix E, and I have scrolled down in Appendix E to the U.S. Preventive Services Task Force statement on potential harms of treatment. Now remember, they had in mind a screening program when they wrote this. They say that an examination of the literature on the harms of weight management programs found no evidence of adverse effects on growth, eating disorder pathology, or mental health. Other harms, such as risk of exercise-induced injuries, were considered minimal. Serious adverse effects were reported for 2.7% of the patients who were taking sibutramine. In this statement, they even cover treatment, including drug treatment of children. So what they conclude overall is that the potential for harm of a screening program is not greater than small. That's how I think they put it, right, Shalina? Isn't that how they? So what you now have in Appendix E is the most highly regarded authoritative body with respect to public health recommendations that has decided to recommend screening and has concluded that the risks of screening and intervention are so minimal as to encourage you to go forward with the screening program. So you might be able to use this statement to help you in your sell to the administrators and political leaders in the community.
I think your biggest allies are going to be your PE teachers, because they, on the Fitnessgram, for years they did heights and weights. Some of them actually sent letters home, but where they're looking for backup from the community and support for what they have now, for those that have been there long term, seeing the growing of these kids and how less active the kids that are big are.
Hi, this is Katie Bart. Can you hear me?
Hi, Katie.
Hi. Oh, Barbara and Mary and can't remember the other person's name. I'm sorry. This has been a great presentation. I just appreciate you sort of covering, a really comprehensive approach as far as making sure, you're in communication with parents and the link to the School Wellness Committee. And I just wondered if, for Mary and for people, are they also looking or relating it to, and this isn't in the same age group, but I mean, I guess I'm thinking a lot of schools are investing in the survey of the Youth Risk Behavior Survey. And I know that is just, self-reported data. But I just wondered if that was also being looked at at district levels. And then, Mary, I think you mentioned the Fitnessgram, which I know some of the other large districts also are doing. And I know in Bozeman, because of the concern from the community, the School Wellness Committee looked at doing BMI surveillance last year, and they decided they did not want to do it because it is part of the Fitnessgram, but there was so much concern about concern with linked to eating disorders that they didn't go forward. But I just wondered if schools were looking at either the Fitnessgram with this and or the Youth Risk Behavior Survey as the kids get older.
Well, when you look at the Youth Risk Behavior Survey and the percentile, it's way below what BMIs, congregate BMIs nationally are saying about weight. So I just don't think that the YRBS is a great tool for getting this data. I mean, that's just my thought on it. I don't think self-reporting is ever a great tool for any of our problem areas. I think I would refer back to this document that Barbara was just talking about, the damage. And I don't think that that's a legitimate argument. How it's done, that can be damaging. So I think that it's important to put in the safeguards for kids and parents to opt out, and for kids to have it confidential, and for when during the little 2-minute time it takes, that that you have very good protocol on how you're interacting with that student is very important as far as damage or no harm. So that's my thought on it.
I agree.
And on the fitnessgram, they don't do the BMIs on the fitnessgram. They just do height and weights.
Yeah, no, that's I do know that. I just didn't. They weren't even willing to do the heights and weights to go there in Bozeman. So I guess I'm interested. I was interested in your opinion, and I do see that the youth risk behavior survey is not accurate. But I guess I feel like it's one thing that's, it's one of the one things that school districts are doing.
Right, it is. There's no doubt about that.
I feel like it's not utilized at all. So I'm just wondering if it is the best tool to be looking at, and because of what you brought up. I guess the other thing I wanted to just make sure people are aware of, and Mary, especially since you're in Missoula, you may know, sure you know Dr. Gaskell and Dr. Arthur Miller.
Right. Mm-hmm.
For them, well, Dr. Arthur Miller developed a recess and action guide.
Right. Mm-hmm.
Schools can utilize that guide and have some training. The Office of Public Instruction is supporting some training and distribution of that guide to help kids, just have some games to be able to, they don't want to play on the swings, some fun games to be active at recess, because your point about the 10 minutes of activity is a very valuable time, recess can be. So I just want to make sure people are interested in that recess and action program to contact Dr. Miller at University of Montana. Everybody, it's now 5 minutes over, and I just want to thank you all for participating and for attending to this presentation. And I want to encourage you to contact us if you have additional questions that occur to you, in the future. I consider this such an important topic. I really am committed to helping you make this happen, and if your local school district or community is interested, and so I'm at your disposal, and I'm sure Mary and Rachel are too. So thank you so much for your participation and your interest in this topic.